Welcome to Healthcare Rounds. I'm John Marchica, CEO of Darwin Research Group, and your host for today. I'm excited to bring to you Jason Bryll, who's a principal at Parable Associates. And today we're going to be talking about data, finances, value-based care, a lot of stuff that a lot of people are focusing on today and being able to affect change in healthcare. So, welcome, Jason. Thanks so much for taking the time today. Really appreciate it.
Yeah, I appreciate the opportunity, John. I know you've had a lot of great leaders in the podcast, and it's really helped the healthcare community. So that's what I'm focused on, and hopefully I can do the same.
Excellent, excellent. Well, I have a ridiculous number of questions, so
All right.
trying to be in keeping with our time frame. I'll try to limit it to the ones that are most essential. But as always, I come to these things and I prepare with all these questions, and then we get into the conversation, and then it's like, all right, well, I guess it's kind of backup at this point. But why don't we start off by looking at your background. You've been all over the place, and I mean that in a positive way. I mean, you've been in VC, health systems, advisory work, and now here you are with Parable. And I just want to know, what really got you to focus your attention on healthcare innovation and be in this space now? What led you to where you are today?
Yeah. So I'll give you the Spark Notes version and kind of some of the highlights. So when I graduated from college, I got into healthcare, and it was kind of happenstance that it worked out. So my first job was with a company called Accretive Health, and they were a consulting firm. They still are. They're now known as R1. So they were a consulting firm. They helped typically large health systems with their revenue cycle. And I
Hmm.
came in as a site finance lead. Very quickly, I became like the Excel guru, putting together spreadsheets, doing all the different math you'd want to do on really um, the total cost to collect, and then where are the opportunities for denial reduction, these types of things with claims processing. Um, and I did that for a couple of years, and then I had an opportunity to go to another consulting firm called Meta Assets. And there I became the director of assessments. And so I became the one who actually had to take a step back and look at typically the revenue cycle, the workflows, and see where do the opportunities lie for process improvement. Um, Wanting to get off the road, I implemented Epic at a hospital system in Greenville, South Carolina. And it's now known as Prisma. At the time, it was just Greenville Health System. And I
Hmm.
led all rev cycle apps. And so I took that expertise of really trying to identify where there's gaps in the workflows, and building that into an Epic installation. And then the last stop before Parable was a company called Alvarez and Marsal. And that was probably the one that I would say opened my eyes to a lot of what's happening with private equity money and things that are really consolidating
Mm.
groups together. And so, a lot of groups that were, let's say, specialty care, going from, 20 providers that were partners to hundreds of providers in a large group. The dental DSO space, a lot of that is what I got exposure into. That's what triggered the awareness that, hey, there's a market here, an opportunity to be a data leader in that space. Because what I didn't see at the hospital systems, I saw large data teams, data engineers, data architects, business intelligence solutions, all being implemented and deployed, as well as a whole ecosystem of support vendors. But in the specialty care side, there wasn't the same infrastructure. And so you had a lot of specialty care based EMRs. In urgent care, you have Xperity, WebPT and physical therapy, and Prompt now, and ModMed for dermatology, as well as many other specialties. So you had these specialty based EMRs, and nobody was building the data warehouses. Nobody was building the BI solutions. And so that's really where I said, hey, there's an opportunity here to help these growing practices consolidate all their information together clinically, operationally, financially, and really turn it into meaningful information. So I started that in 2018. Fast forward, and now here we are. We have a much larger team, and we're split between US and India, and have 30 FTEs and growing.
So my question is why? Why is it? So I get the dynamic that you're talking about, and you're definitely serving a need there. But considering the importance of all specialty care and all these different um, elements of care delivery that have to be part of the whole, you know, puzzle to understand the puzzle, especially in a value-based care environment, Why the lag? Why weren't people really making that leap and incorporating that kind of information into their decision making?
Yeah. So there's going to be a lot of history in that question, probably some that I'm not even personally privy to, but like at the highest level, let's just say, again, right now I've been in hospitals, but right now, like the specialty care space, or even like orthopedics, and we got the ASCs and so on. Um,
Right.
and so you have an ecosystem where everybody's on different applications. And yes, there's some interoperability things. There's some HL7s that became, general requirements, and so on. But at the end of the day, you have all of these different technological things happening in every system. That Jason Brill's a different MRN, right? In between all these different platforms. So following that patient's care through the whole ecosystem is incredibly challenging. And then
Sure.
you say, hey, there's even within these growing practices that that I service today, they're growth by acquisition. And so they have multiple EMRs even within one org. That patient traveling just within that, its own internal ecosystem of providers is really, really challenging. So I think, my interpretation of all of this is it takes a lot of technology to properly grow and lead a healthcare practice or a hospital system, a lot of different technology, and they're not all built where they connect directly. And it's grown so fast. There's so many different healthcare organizations that have grown so fast. They built it for a smaller organization. And then when it blows up, again, private equity, money, different things happening in a 10-year, when 10 years is still short in terms of business life cycles. So it's a lot of change. And I think right now we're seeing that investment to track and follow that care through, as well as, all the activities that each provider's doing.
So taking us to that 30,000 foot level, here's your easy hard question. So what are the challenges that and I'm going to keep coming back to this sort of value-based care refrain. But what are the challenges in the specialty space and even in general when you're trying to like see the big picture, but you have these sort of competing revenue models? What are the challenges that you face as a from an analyst standpoint, from a financial standpoint, CFO type standpoint? Like, what are some of the issues that you run into?
Well, as it pertains to the reimbursement models in particular, there's just a ton of fee for service that still exists today. And so I'll lean into the tech side a little bit here too and say that's how the
Yeah.
technology is built to service that fee for service model. And if we look at let's just talk about like PT. So somebody that has a major surgery and then has to go through a series of PT, and that PT may not be directly affiliated with the hospital system that conducted the surgery. So in that scenario, how do those referrals come in, and how do you measure and monitor the success of that physical therapy? And what if the patient kind of falls out of attending or properly following through with their treatment, plan? It's incredibly challenging to follow that patient through. And it's not to say it's impossible, but when you don't have a data warehouse, when you don't have the APIs or the HL7s, those types of things set up, and you're not monitoring it, there's no like single governing body over it, being like a large health system that has all the specialties built within it or joint ventures. It gets really, really challenging to just navigate that data and monitor that patient all the way through. So I mean, honestly, as we talk through it, I feel like there is an opportunity if true value-based care in those types of reimbursement models are to really grab hold. There's a need for some sort of centralization of that information and standardization that just, again, the technology is not even being built for it in that direction right now. So I think, it's a complexity that we need to build. We need to build the highways, right? Just like in like the interstate highways, but for healthcare. And we have some of the tools in place, but I don't think anybody's really forced to invest into it, to forcefully invest into that infrastructure.
Well, I can tell you as a patient. So I just recently had shoulder surgery. And I was thinking about, you made the comment about the ASC and maybe it's not part of the system. What I was astounded by, Jason, is, first of all, this is one of our here at Darwin, we'll just say one of our more highly rated health systems in general, but also from a technology standpoint. And what I can tell you is, in all of the different elements of care delivery here that we're talking about, whether it's ASCs or physical therapy or imaging, all this stuff,
Yeah.
every component was owned or managed by the health system. And I can tell you, as a patient, as I was just talking about this the other day, I'm going in for surgery to the center where I had been multiple times. I had multiple doctor visits too, but going into the surgery center the day of my surgery, and I'm handing over my insurance card for like the 5th time. And it just, like, I know we're a little bit off topic here, and maybe I'm a little sensitive, Jason.
I love,
but this is
Yeah.
this is real world, and it's the day of my surgery. It's like 45 minutes before I'm scheduled to be there. I'm sitting there with my wife, and I go up to the counter and all that, and I was gonna make us think about it. And my wife is a nurse. She was like, "Will you stop? Just, get your health system ahead. Turn that away. You're here for surgery." But it struck me as being remarkable that I kept getting asked for my insurance card. By the way, after all this, another request for all of that with PT, even though it turns out now I'm paying that with cash, because of the what the payer is willing to pay and what I need to have done. But it's just remarkable. How does that happen? How does that happen in a highly functioning HIMSS, 6, 7 kind of system, with, at least in terms of their hospitals? How do you get to that place where in 2025, the sort of 5th scan of an insurance card?
Yeah. So, not being part of that system, I love that you use this example, by the way. Not that I'm part of that organization, so I'll kind of speak in generalities a little bit. So number one is, it doesn't have to be this way. Not every experience with patient care in 2025 is this way. There are tools and technologies and organizations that have implemented things like Epic across their whole ecosystem. And so in this example, if your procedure was done at the facility that has Epic, and then at the ASC that's owned by Epic, and a provider that's actually employed by that organization that's on Epic, it should be much more seamless than that. The PT, typically I see those being separate and more of a referral relationship. And so that should have been much more seamless, where you have the image and it carries through with you, and it's in like a MyChart type of app. What I've seen is that ASC might be part of more of like a joint venture and not really directly affiliated. And it may not be on the same exact instance or the same tenant of Epic. It may be, I forget what it's called, but they basically can redeploy Epic into other organizations. So then there's like this firewall of information that says, hey, that patient and that record and so on is over there, and we can't bring it over here. Again, there's certain security features that you can turn on, and you can start opening these up. But that ASC may have been on a different platform. If they're not using the radiology platform, they're using a different one. Those images are through a different platform, and those charges. And then that provider may be coming from their home practice and not actually employed. It's a little deceiving to most patients. They don't think about it, but that provider may be a local surgeon and an orthopedist or whatever, and be over there working on your surgery. I've honestly, even to this day, still seen instances where there are super bills. So paper charges coming back from an ASC to a home practice to bill out the professional charges. This is like still happening today, right? And so why does that happen? Yeah, I mean, you may have the ASC. So when I talk about the super bill and the professional charges, and then the facility. So the facility typically is the AAC, the nursing staff, the radiology machines, those types of things are all on that side, and the professional is different. So while it may look and feel to the patient very seamless, what I'm talking about is a very disjointed legal and financial relationship between all of those different platforms. And
you've hit it.
Yeah.
Legal.
legal and legal, those that patient record and that healthcare information, it creates divides. True story. I was literally just pitching in talking with an organization. It's in the same exact type of model where it's an organization that has providers and surgery providers, and then they have a joint venture with an ASC, and they're all the data is in one platform, one EMR PM system, and technically it belongs to the orthopedics group. And the ASC says, we want some of that information for our own BI tool and utilization. And it's like, they can't go directly to the PM EMR. They have to go through the joint venture relationship, but they don't have the IT staff. And so you can see here, like if that entity that owns the data, quotation owns the data, you have these barriers put in place, and it makes it very challenging.
So let's play this out. I'm the CTO, CFO, whatever. I pick up the phone, I call, or I guess these days it might be I reach out to you some other way than just calling you. But I'm that person, and I'm getting these customer satisfaction scores that have been kicked up to my desk. And you said something. Quick side note. You said something about it feels seamless to the patient, but it's not. Not if, I mean, it may have the illusion, right? The shrink wrap, the branding, the facade of the seamlessness, but the reality is that it isn't. And by the way, I know you're using Epic as an example, but I'm sure you'd tell me the same thing if it were Cerner or Meditech or any of these other systems that have the same kind of issue. So I'm calling you and I'm saying, hey, Jason, I need help. I need you to come in here and help us, through your dashboards, through everything else. Can you help fix this problem? How would you address that? How would you approach this? Understanding too, and I'll throw in another wrinkle, and maybe I'll go back to one of my original questions here, which is we're all kind of operating in this journey to value-based care, right? Where we're trying to get better outcomes and we're trying to keep costs under control and patient satisfaction and all of this. What's your process? What would you do? How would you approach this problem?
Yeah. So, well, first, the exact problem that we're talking through is probably not like the first thing that I would solve through my own firm and company and the services that we provide. So
fair enough.
We typically, so just in transparency, let's say the large healthcare practice wants to their own data model, their own data set, practice operations, manage no-shows, manage, whatever the time entry for providers, provider comp models and so on. So like that is the world that I live in. But in the instance where there are these, let's say, joint ventures or these relationships, there are interoperability opportunities. There are methods where the data team members like myself, the data team, we serve as like an augmented staff, and not to do like a pitch. This is just kind of how we would function. We serve as that
Understood.
Staff, build that warehouse on our client's tenant. And then through that joint venture and operating through that legal relationship, we can make data accessible and meaningful to both sides. There are these things people talk about all the time, like these APIs. A lot of systems open up read and write APIs. So in theory, and we can help set those things up, and so could many data professionals and product engineers. So that data that comes from a specialty-based EMR may have an API that says, oh, we can actually send this directly over. So as that patient goes from, I'll use different ones, from a mod med to a web PT, that those APIs can then create that patient on the next side. Now, it doesn't necessarily mean that image of the insurance card comes over. It really depends on how much is opened up by each EMR. So the structured data, creating the patient record, we can make that pretty seamless. The imaging, if they have the same imaging platform, the same document management platform or something like that, there may be opportunities there. But the reality is it remains an opportunity today for most of these organizations. It's not a perfect, there's no perfect solution and solve for it. And again, we kind of talk through the reasons why, but there are ways to kind of ease the burden to some extent.
I just think that, this problem, and it's probably called, there are fancier labels around all of this, but this problem of, moving to a higher level of integration. We'll just call it that. I get that, at least in theory, the Kaisers of the world, and that kind of model with roots in managed care and all of that probably has a better shot at it. But the vast majority of the larger health systems across the country, everybody is trying to do sort of the same thing. We all want to be on the same page from a data standpoint, from understand our financials and all of that. And yet the actual execution, I don't even know how to measure that, other than measure that as a market research type person or as an analyst type person. I don't know how to measure it, but it seems to me that it is a major problem in healthcare that, to me, feels like low hanging fruit. That's the problem has been around forever, and it just doesn't seem to be getting addressed. And so I guess my point is, when setting this up, I was really excited to talk to you for this reason, because I had this recent personal experience, and I wanted to, see like, well, how would you attack this?
Well, here's you bring up a good example with Kaiser. Kaiser's obviously got a very wide network established of different providers and specialties and so on. And so I think that when you have really large health systems, you can avoid a lot of this, because those should be operating on the same network. Again, I don't know your exact details on where you're at, what technology, Epic, Cerner, or otherwise. But I do think that that's there. From the technical side, when and how do these systems talk to one another? From the rooms that I've been in, especially when I was doing implementations and so on of the actual EMR platforms, a lot of the data that's being transferred between health organizations, the energy and the financials have been focused on the clinical use cases. And so getting your medical record over from one place to the next to follow that along with you. Sometimes the financial data is not as accessible. They just haven't moved that far yet. So, just from an investment standpoint, I think it's more likely that your PT had some level of history of your shoulder surgery and what took place. It's more likely they had that than they had your financial data. As far as the financial data, here's some things to think about. You mentioned scanning your insurance card. So I'm thinking in my head, I'm thinking about eligibility and authorization, the patient access workflows that I'd be kind of leaning into. So in that setting, one of the other pain points for the providers is getting paid. And it's unfortunately, denial rates have gone up to over 10%. I used to, when I was doing my consulting days, for Accretive and Med Assets, we would say best practice is probably 5% or less for that initial denial rate. And then your write-off is significantly lower. And now it's just crept up. And I see a lot of eligibility and authorization related denial activity. And so, as such, if you're a healthcare practice, if you're an owner or you're operating that group, you're going to be extra strict with your policies and procedures. You got to get the card, you got to get the scan, you got to run eligibility through the portal. You got to do all these things. Even if it's duplicative for the patient, we can't expose our business to that risk of not getting reimbursed because we had an old insurance card and you just changed employers in the past month. So, it goes into if you have a little bit of empathy for the other side, right? That's what I usually tell my team is think about if you were in the shoes of the customer, but in this case, if you're in the shoes of the provider, even though they're the ones providing you care, why are they asking you for that card? Well, it's because they got stung at some point along the way.
Yeah, I can see that, but without taking up too much more of our time and talking about my own personal issues, I can say, signing up for multiple portals, getting text messages that look different, feel different, for reminder appointments in different stages of the care process, right? So that's where I kind of come back to, there's the facade in some cases. And by the way, this is a very good health system, and I had a very good surgery, and I'm happy with my recovery so far. So and the only reason I'm not naming is because I don't want to throw anybody under the bus. But it's not just that sort of 10%. We've got to bring that down into something that's more reasonable. And it's possible he might have lost his job in the last 15 days. And so let's get the insurance card again. it's endemic.
Yeah.
And so the one half of the equation is, well, there's the customer experience, and there are quality scores and other things that, especially if it's for Medicare and CMS and all, they may have other value-based arrangements where they're getting bonused or dinged as it relates to customer satisfaction, right? But it just seems to me that there's the patient side, but then there is, as you said, maybe the first line of attack is making sure that the clinical information is accurate and coming in from all these different places. But in terms of revenue cycle and moving to this new, value-based reimbursement, that's also critically important too. And so that's kind of brings me back to, what are those early conversations like when you come into an organization, specialty organization, hospital-based organization, or health system? How do they prioritize these things in those early conversations about what's most important to them as leaders in that organization?
What's interesting as we're talking through this is the person that typically brings us in is the CFO and not, the clinical, the chief clinical officer or what have you. So I think and I'm thinking through some of this out loud, just based on the patient experience that is happening within the healthcare organizations and the multiple portals, because every organization is going to have their own, version of it. And every EMR is too, because it's proprietary to their platform. But the financial and the revenue cycle side tends to be a large pain point for the health system as well. So it's impacting the patient and the health system. And so there probably is, if we're to take a step back, something that's mutually beneficial on both sides. What typically the conversations I have are largely around figuring out where that leakage is taking place financially, figuring out where there's opportunities to really fill provider schedules. And because you typically, in a lot of these organizations, you have a large backlog of patients. So how do we maybe see them sooner? How do we get them in faster, both for clinical reasons as well as financial, to optimize that opportunity?
Right.
Yeah.
Right.
And so we provide services to help with that. Although we have a lot of conversations. How do you do it today? How do you, and so on. And then same thing with rev cycle. We monitor a lot of things around payments coming in, how fast they're coming in, and largely because these organizations, and I think about this too with value-based care and capitated models and then the fee for service, like all the different models. One of the challenges that people don't often think about is those insurance companies will often pay 25 to 30 days after service if it's clean, no denials, no nothing, and if there's no deductible.
Sure.
So like the importance of getting that cash flow is critical. So those are where my conversations typically lie, is how do we improve from 50 days in DSO down to 30, because we need the cash on hand, we need to operate our business and invest into the future. So that's really typically where we start.
I would be remiss if I didn't ask this question at this point in the evolution of healthcare. What about AI? And specifically, what kind of tools can you apply, or that you've seen applied, to really improve this whole revenue cycle? And I guess the second part of revenue cycle management, then the second part of it is, can AI address these different payment models that you just talked about, capitated, bonuses, more outcomes-based bonuses, things like that. What do you see the role, and what have you experienced in terms of AI?
Yeah, I'm very pro AI and these large language models and the things that it can do with massive amounts of data. So, we're in our infancy right now as a healthcare community and organization, and there's reasons for that. I'll start with how is AI and AI tangential things, how is it being applied today? One thing that I want to make sure we don't confuse is AI and RPA, or robotic process automation. RPA has been around for a while, but it is better than it's ever been. And so what I'm seeing is, let's say you go to an organization and you are scheduled for a service and they have your insurance information already. A bot can go into that Blue Cross Blue Shield of Arizona, not that that's your insurance, but if it was, they can go into that portal. It can check your insurance. It can say, yes, you're still eligible. It can get that data, go back in the host system and say it was checked. they can do things with found coverage now as well, with these bots. They can do payment posting and things in the back end as well. So as you get a large batch that has to be scanned from a PDF. So these bots do exist, and they're helping the scalability and the speed at which practices can operate, specifically, again, within RevCycle. There are many applications outside of that, but any workflow that can be documented can be automated. Right?
I was just going to say, you're really talking about automation tools.
Correct. And then, so here's the next part that it goes to, and I'm seeing a little bit of this, but it's not perfect yet. So you take that automation, but now you throw in a wild card where AI triggers. And it's a non-healthcare app, but there's one that I was playing with for my own business I think it's called Lindy. But you have basically an RPA workflow, and then you say, okay, now we need like a Chat GPT or Gemini AI agent to write a letter or write an email or write a denial appeal or whatever it is. We need something that's going to be AI related, that's going to insert into the middle of this workflow. And so obviously there's going to be great use case for that. The challenge in healthcare is, how do you do that on a closed network because of obviously data security requirements? When people say like, oh, I go into Chat GPT and I say, I'm going to Colorado on vacation, what should I do? Make an itinerary. You can't do that with Jason Bryll. Is this medical record? He hurt his shoulder, blew out his knee, whatever. You can't do it.
Right.
So, healthcare is going to move forward in inches, not miles, when it comes to the full value we can get from AI. But there will be pieces of this puzzle that are going to start to be put into place. The one thing that's really interesting on the data side that's already happening is text to query. And so it used to be, hey, I have to know Python or I have to know SQL. And we're now seeing certain platforms that have AI generated answers. And this is something that, my firm's getting into, and we're interested in doing more with it. But if you give it a data model, you can ask free text questions in a normal fashion, right? So how many times has Jason been here in the past year? And it's going to give you the answer, right? So these types of things that are AI and thinking about your question, converting your question into a SQL statement and writing that into the database and pulling it out instantly, these things are starting to happen. So it's really fascinating. It's really, exciting moment. You can obviously say, well, let's grow the data model and let's spread it across multiple data systems. The layers of security are going to be a challenge, but how do we monitor that patient between all of them, not just the one that I'm building it on? It's going to be really interesting to see how that plays out in the next, 5 years to a decade.
Yeah, actually, we've been for quite some time now been experimenting here at Darwin with some of those kinds of tools, just extracting more information out of what we already know and what we already have. But I think that we're a ways from that happening. One of the things that it's going to seem like an oddball question, but as we're kind of getting to the end, I'm just curious about, do you have a sense of, and then you can just flat out say no, but do you have a sense of innovation fatigue among, what I mean by that is, these health systems dealing with all this data and these specialty practices and all of this constantly being pushed to the next thing, Do you ever get a sense in your meetings or a meeting with people like there's a bit of fatigue is setting in to just say, can we just let things be the way they are for a while?
No, I don't see that. I don't. So here's a quick example. I was just talking with another business leader about this topic, and I was talking AI, and I'm big, obviously pro AI, and I think there's a lot of work to be done. You don't just implement it overnight. But he brought up like, okay, it was big data not too long ago, and then it was blockchain, and some of these things, like, they just never quite applied perfectly. So there may be use cases or applications, but like the global impact wasn't there. And big data is there. We just rebranded it and just say like, okay, it's our data lake, data warehouse, and our solution. Everything's big data as we accumulate more information every day. But anyway, so when it comes to like innovation, I was just at a conference, this happened to be an urgent care conference. When I was just at this conference, somebody demoed an AI voice agent for inbound phone calls, because most at urgent care, a lot of times you just pick up the phone. Are you open today? Oh, I have a cut on my hand. Should I go here or the ED? Right. So like you get these basic calls. And so now there's an AI agent that can actually answer it. the buzz around the new innovation was massive. It was just just talking amongst, the network that I made at the conference, it was a buzz. And whether it's that innovation or something else, there's now a technology in AI and these large language models and so on, and machine learning. There's now a demonstrated use case. And that's what's causing the excitement. It's solving a problem. As long as you're solving a problem, you won't have the fatigue. So I think the other things, it felt like fatigue. This doesn't. This feels like, oh, can we just layer the security in properly? Or can we do this one extra thing? And so a large health system that I spoke with, they told us that before they do anything AI, it has to go through an AI committee that they have. So don't assume that everything is adopted into large health systems overnight. It's going to go through strict review, but go downstream. The pains that they feel at these small practices it's going to be so helpful for them. They'll be early adopters, and then we'll see it move its way upstream.
Well, the reason I asked the question, maybe it wasn't the right analogy, but I was thinking about, in the last decade, especially before COVID, with like the ACOs and a lot of the hospital quality indicators, there's a very real, we got to track this data set now, and now we've got to be submitting this. And you said this quality metric was important last year, and now you're telling us that it's not important this year, and kind of a throwing up of the hands, right? And and that's all about innovation and getting better. But you answered the question in a way that I had expected it. By the way, my follow-up is, what made that voice assisted or AI assisted assistant, what made that different from the typical prompts that for decades we've been accustomed to on our phones, trying to work your way through, asking you questions whether you want a flight, or how was this different?
Yeah, it's so just like if you were to have a conversation with ChatGPT, if it's something you played with or listeners have played with, it would respond to anything you asked. I mean, it would have a conversation with you, and it's been trained to have these more urgent care specific medical conversations. And from a buzz standpoint, I mean, there was a large urgent care group that said they reduced their inbound manual handling of phone calls by 50%, which for them was massive at the front desk because that's who handled all their calls. And so, that sounded very appealing. That's to say that sometimes you do get to that spot in the prompting where it goes to a human to intervene, but 50% is a massive improvement. From a patient perspective, it was conversational. It's not press 1 to do this, press 2 to do that. You're not navigated through that way. It's open conversation, open dialogue, and it's reading and reacting based on what you're saying. So as soon as you get on the phone and you say, what, are you open today? It walks you through and says, here, we're open from this time to this time. Would you like me to check you in? We have availability at 3 p.m. So it's also kind of filling this gap of like, okay, let's incentivize to get you in the door from an urgent care perspective. So it's a different thing altogether. It's not just happening in healthcare. These voice agent companies are going multi-industry. I see it in a ton of outbound sales. I get them, unfortunately. And I say unfortunately because I'm a business leader. I'm bombarded with them. But overall, though, I think it's a huge win for these healthcare providers and really being able to scale.
So while we wrap things up, Jason, in the next 18 months, from your standpoint, as we're thinking about trends in rev cycle management, trends in data management techniques, and all the things that you're like, what are some of the things that health system or the leadership of these provider organizations, what are some of the things that these leaders should be on the lookout for over the next 18 months? Key trends.
Yeah. Obviously I'm a data nerd. And so,
me too.
Yeah, I think, the key trends are the more that you have access and control of your own data, the more opportunities you'll have for automation, for AI, for these types of advancements. I anticipate there's going to be a lot of, advisory within these as well. So interpret the data and provide, a recommendation. So I really think, 18 months is a pretty aggressive timeline for healthcare, but it could happen where this doesn't only trigger the data community with like a new innovation and so on. This could also impact consultants and so on. And those that use the technology and are actually deploying it are the ones that are going to scale rapidly. So taking your brain and putting it into one of these agents, as a lot of people call them, I see a lot more of this activity taking place.
Outstanding.
Yeah.
Outstanding. Well, Jason, thank you again for taking the time to talk. If people want to get a hold of you, how do they do it?
Yeah, you can get a hold of me. My email is jason.bryll@parableassociates.com. You can go to parableassociates.com, hit the contact us. It goes right to me. And LinkedIn. I'm trying to post as much as I can on there. So look for Jason Bryll, Bryll on LinkedIn.
Great. Jason, thanks again.
Thanks, John. Appreciate the time.
And that'll do it for another episode of Healthcare Rounds. Our guest today has been Jason Bryll with Parable Associates. And as always, I'm John Marchica, your host. Do us a favor, leave us a review. I've noticed that haven't seen any new ones coming out lately, so please rate and review wherever you listen, or if you're on YouTube watching this, please subscribe and leave us a comment. See you next round.